know the development and the expectations of facial harmony, right? But then, like an orthodontist has the vision to see that if you have a patient with a triangular shape into the uppers and you can see that mandible trapped, you can expect as an orthodontist you have the experience, and then you know that as far as you develop that arch into the upper, that mandible will float, and as far as you making the alignment arches, that bite is going to settle in a point that you follow in the growth of that patient, like just giving them what they don't have. So the analogy with this is because we knowing that is effect of the human stomatognatic system balance that start for the soft tissues controlling the arch to the lips that you will talk about it, the buccinator, the buccal slim as we call it, and developing that external part, but also the internal part with the tongue that we're allowed to develop, and we genetically coded to be developed, but because the environment or many other conditions, maybe we constricted. So we understand that that mandible will flow, that we become to a position that was not possible to be expressed before. So my question is, why sometimes we see too much retruded orthodontics? I'm not generalizing, but it's something that we normally see often, that most people try to bring things a little back. And I'm not saying that is your case. I'm just asking you an opinion about, because I know that you address that part of the growth and development. And technically, this is one of the parts that I like, how you treat the teenagers, because you're in that specific time of transition to help that person to balance the entire body as a unit. So why it's difficult, because I don't understand ourselves many times. What is so difficult to correlate the both things? And I say the body expressed this way when I have crowding, and I can see that mandible go. And then why sometimes I will try to retrude that mandible back. Can you follow me, Hamid? Maybe I need a translation in that.
No, I understand what you're saying. So
Okay.
I have the fortune of, teaching at the university level, but that was after having been in private practice and being a clinician for almost 20 years, making observations and seeing the trends in orthodontics, the trends, and the general trend in orthodontics is still, the best time to treat somebody is when they're teenagers, when there's a full complement of permanent teeth, and I think that mindset is starting to change, because we now recognize how important it is to start early and identify early. So what you're seeing is probably a consequence, because I treat a lot of adult patients as well. Probably 50% of my practice are adult patients who've gone through traditional orthodontics, who now have their occlusally challenge, airway challenge, posturally challenge, all the above, okay? And then I have a good percentage of them are also young adults, late teenagers who've already gone through 1 or 2 rounds of orthodontics, right? And the very, thing that you described is they're trapped. They're these underdeveloped faces, but they have a great class 1 fit to their teeth. Mm-hmm. And I think that's what it comes down to, is that.
Thank you. That's what I want to go. Awesome.
Okay. Their goal, that orthodontist goal, and again, no judgment, but being a boarded orthodontist as well, teaching at the university, their goal was getting the teeth to fit together in a static relationship so they could achieve a class 1 occlusion. But what they, forgot to do is take a step back to look at the whole person. So, and I think that's the problem, is that we're still judged when we refer a patient back to the general dentist, or a hygienist is looking at a patient. What's the first thing we always say to a patient? Bite down. And then what we're being judged on is the fit of the teeth. But how often do we ask the patient to move into these different, I call them my test positions, to see if I actually achieve a functional occlusion goal? And then more importantly, take a look at the patient and say, is the midline actually balanced with the face? you know, when they're smiling, are they asking the patient to sit up and smile for them to see if there's a cant or not? You know, you're looking at the patient from above. Are you actually observing the patient as they're walking out the door or sitting in your chair? You know, so these are things that you have to choose to look for if you're going to treat a whole person. So I think we get caught up with thinking and treating segmentally, because that's what we do in dental school. It's all about requirements. This number of, you know, 3-unit bridges, this number of dentures, you know, it's unit based and segmentally based. And I think that's one of the concerns and challenges. I know that, you know, one of the questions that I'll be asked later on is there a way to make this change at the education level? Well, it starts with literally dental school, not the postgraduate level, dental school.
So if I'm hearing, it sounds like you were very lucky to have the right teachers at the beginning.
At the very beginning.
Correct.
Yep.
And that's really makes the big difference. People planting those seeds early on to keep your mind open, because you're absolutely right that the way we teach is very much like a military school.
Mm-hmm.
With a lot of limitations.
And it's on a static thing. And that's one thing we have always been talking with Javi, that when I talk with a lot of the orthodontists, I see that they're still looking at, you know, that cephalometric analysis, and a lot of the parameters they're looking at is very static. And I always say that, hey, we need to infuse. How do we infuse some physiologic parameters into this environment? How do we stop looking at just those bony points, which we know it's already distorted because the growth didn't happen right? And how do we infuse that?
How do we infuse that? I think that's going to be based on the individual who, you know, gets to that student first, you know. So one of the things that we have to do is it's that's really a complicated question, because it you know, I have to be careful. I don't want to offend anybody, but there's an institutional component to it, you know.
Tell us how did it happen to you? How
did it happen to me? I think, you know what happened. If you ask my parents, I think it's because I was the kid who always asked why. If you ask, you know, Jeff Clendon and my classmate Doug Knight, who really, he's the person who made the biggest difference in my life, because if it hadn't been for him being
you get really good people around you.
You know, when I was a resident, he had to convince me first as to why did it matter for me to mount my models? Why did it matter to stabilize the patient? I had to be convinced. And we had a drive. I was just talking to him the other evening. I said, when was it that we went down and we drove down to DC together? And that was when it was a turning point for me, because he just patiently and quietly just watched me do what everybody else is doing in our residency. Just put the braces on, do what we've been told, you know, what we memorize. And then I saw before my very eyes, the very thing he predicted before even I knew it was going to happen. He's like, yeah, that patient's bite's going to open up. You know, he knew already. So that's when I was convinced there was something that he did that diagnostically mattered. So then I started to pay attention to those things, and I wanted to learn about how to go about doing that. What do I need to do to learn how to see differently and to do better for my patients? But, you know, that's also really individual, Hamid, because I think, you know, you can get caught up with just doing what we're supposed to do. And then, you know, it has to be part of your value system. It has to be part of your core, you know? So,
same values
and again, I'm not judging. It's not judgment, but that's just me. I was the kid who always said, why? Because we're always taught to look at what and come up with a how, right? So like, here's we see, and then, okay, you see a cavity, fill it. You see a cracked tooth, crown it. But I always want to know, like, why is it cracking, you know? So I think you and I spoke earlier before the interview started, you know, you were asking the why. You're like trying to figure out, like, why isn't this working? But that's also not the way an insurance company also, you know, pays and reimburses most dentists. Again, because I have a home office and I have a more boutique style practice, I am fee for service. So I do have, I don't want to say it's not a luxury, but I made a decision when I decided to open up my practice after being in private practice for a few years in a bigger group practice, that I wanted to practice a different way. I wanted to practice based on what the patient needed, not because of what an insurance company was going to tell me the patient was going to get reimbursed for, or what I was going to get reimbursed for.
Right,
So,
okay, let me, okay. Let me, so let me ask you, Dara. Let's just get the people, because I've been talking about how many multidisciplinary tools you use, and like what I'm seeing is that you work with another physician and all that. So even that is part of the questions at the end. Let's try to tell us like what started for you first. So you already tell us about your career in the orthodontic part. But now show us how you start putting those holistic aspects into your practice. What was first? Did you get any, like what was that sequence? Because I think when we start doing this physiological occlusion, and I remember myself when I started 17 years ago, this was like, as I say the day of the introduction, you decide to play the infinity game, because this has no limits. The more you dig in there, it's an explosion of more things. Look at this meeting. Honestly, we realize that we need to keep going and faster to catch up with all the things that you guys do that we don't do. You know, in that point that we can see what is in the middle. So what was first for you with this holistic approach? Because I know that you combine many. Tell us a little bit about that, because remember that we start time limits. So tell us a little bit about what is the influences and what it came. What was that flow for you to make you the holistic person that you are, that it takes care from the head all the way to the top?
So what came first was working and treating the physical therapist who I have on my team. So she was the first person who really helped me connect the relationship between the occlusion and her approach as a physical therapist. She was not only a traditionally trained physical therapist, because all of them go through the same program, but she herself shifted and became more of it's called the postural restoration approach to physical therapy. And their goal, it was in alignment with what I was doing, which is with my orthotic therapy. It was all about bringing the body or the jaw into a neutral position. And we found that, you know, in working on her, we found that what she did with her physical therapy training complemented what I was doing. And then through that, we started to work with patients together and realized that over time, we were getting better outcomes. She was able to see the patient move into neutrality and get to, you know, achieve the goals that the PRI Institute, you know, defines as moving the patient into neutral. And I found that I was able to go through my splint adjustments quicker, and the patients were becoming less symptomatic, and I was able to stabilize them and get to the end point sooner so that I could move forward. So phase one for me in my office, if you have a patient who's symptomatic or there's signs of instability, they almost always have an occlusal orthotic. To complement that, I was then introduced to a physician. She's an integrative physician in my community, who also treats incorporating biodynamic osteopathy. So she's an allopathic trained as well as osteopathic trained. So when she came in for herself, because what happened was she started to see that her patients were getting better with her treatment, and wanted to know what was it that I was doing differently, because my orthotic therapy was allowing her to achieve her goal. So that was the sequence. So I started to develop a team of integrative, you know, healthcare providers, because they became patients of mine as well. And then, you know, Dr. McClendon, the surgeon, that's the dental interdisciplinary team, who had to be part of the process, because many of those patients needed to move from phase one into phase two. In phase two,
so you start from the, okay, right, sorry.
So I start with an appliance, a splint or occlusal orthotic, and I complement it with physical therapy always. And then if there is a component that requires osteopathic therapy, I refer the patient to Dr. Myers. In some instances, patients who I know who are not compliant, you know, because physical therapy requires compliance on the patient.
Yeah,
I have found a structural integrative Rolfer. So we've been doing some Rolfing, but you know, Rolfing is basically fascia release, right? So it's been really helpful in getting the patients unwound, right? But you have to be very careful because it's easy to just lay on the table and have somebody treat you and then start moving and feeling better and forget all the other parts that you have to do. It's truly an integration of all of those things that have allowed me to achieve this kind of wellness approach to my orthodontic diagnosis and treatment.
So we will start from the same point that brings you to something a little more complex and more complex. So you start physical therapy, knowing the influence of the head into the bite and the body, and then you make a little another level more with another modality, and then you continue treating patients. So you were experience changes around your journey of information that you collect, right? So at what time?
It reinforced what I was trying. Basically, it reinforced what I was trying to do for my patients, and then that the most important thing was recognizing that an occlusal appliance was not enough. Yeah. It was not enough. You know, I needed to make sure that the ascending and descending issues were basically being addressed with other therapies, which I don't have the training to do, you know, and you have to basically not only change the patterns here at the level of the dentition and the chewing patterns here, but you also have to change the posture. Because I don't care what you do here, it's not going to be stable unless the rest of the body is moving in the right direction. And it's coordinated and it's collaborative.
It's a two-way street. That's correct.
It's a two-way street. Yep.
And at what time you decide to involve myofunctional therapy? That was on a step later in that, and then you get another level more?
So myofunctional therapy is another referral or adjunct to what I do now, and I pay attention to it more because now I have 3 myofunctional therapists in my community. Prior to that, I had to rely on my physical therapists who had, you know, they'd pay attention to the tongue and to the posture of the tongue and how that is involved in diaphragmatic breathing, right? It's all about centering and bringing everything to midline. But having having myofunctional therapists available to me now has been helpful, and I usually make that referral early on, especially for my younger patients, because if I am going to do any sort of palate expansion, I recognize that oromotor dysfunction, you know, behaviors that consequentially are going to basically compromise my goal, which is to create a stable functional occlusion. You have to make sure the tongue and any other oral behaviors that need to actually be, you know, addressed needs to be coordinated simultaneously. And again, it's hard because children are overscheduled right now, right? So one of the things that we have to do is figure out when is the right time to do this. And then the adults who commit to this, they recognize it because they know that when they make that commitment, it's not you can't just go part way, you know, especially for adults. Children, you have to figure out a program that's going to work so that they're not overwhelmed. In conjunction with myofunctional therapy, we have to also identify why is there this dysfunction of the tongue and why is there low posture. And oftentimes there's a frenum problem. So, you know, at that point, the myofunctional therapist does her or his assessment, and then we collaborate and we determine whether that patient at some point will benefit from having releases. Exactly.
You know, this is funny because I don't know if you ever seen these comics that is a little window and it's somebody stepping in books. And then she reminds me like this, you know, the taller you are, is the more books and information you have. And then you got to see clear. And that's beautiful because this is a clear proof that we can be whoever we want. That is just
That's
the
right.
vision it will make you and the time that you put to build yourself to see with different ways. Now, this is beautiful, but now we need to start seeing a little bit about your workflows in reference with that moment that you're going to start taking records. Um, I don't have much information about the concepts of how you guys try to get the bite. Tell it honestly, I've been hanging with Jeff, but I think we start hanging more with the wine than talking about what we have to talk, because always this is a question that I have is I
Easily
want to
distracted.
know what is the technique, you know. Tell me a little bit how you guys take the bite. I know that you guys also talk a little bit maybe because you connect the conversation with the kind of appliance that you guys use that I think is called Mago. And just a little overall about your philosophy and occlusion and thinking, and then we will go over Hamid and we go with the basic questions.
Question.
But teach us a little bit about your workflow and the philosophy behind how you take the bite registration. What your thinking process? What you do?
Oh boy. Okay. Gosh, I could talk a long time about that. So from a workflow standpoint, every patient, once we determine that they would benefit from having diagnostic records taken, we always take 2 bites. I don't know if you all know this. I know Javier knows this, but I use an articulator. I always, whether you're 5 years old or 75 years old, all of my patients have mounted models. So we take a centric relation bite. So, you know, basically what does that look like? Usually it's a 2-piece power bite. It's a technique that I learned from my training with Dr. Roth. And it's basically
Is that by
like
manual manipulation?
it's not bimanual. Nope, it's
Uh-huh.
not bimanual. Nope. I
Okay.
basically my technique is basically allowing the patient and trying to achieve a rotational movement of the mandible, and it's not manipulated. I might guide the patient so that, you know, if there is a posterior interference that causes the patient to deflect, the goal is to basically capture that before they actually connect
Happen.
with that interference. So it's a bite registration where there's disclusion at first point of contact. And then that's an anterior bite registration. And then it's basically like a class 3 lever. And then I take a posterior bite registration, and it's not a full wafer going across. That's an old technique. I just use like a PVS material that I flow in the posterior teeth, and then it's just an index. And I know for those patients, when I do my initial records, it's centric du jour. So, you know, it's not going to be perfect. Children for sure are easier to guide into this, you know, centric relation, axis of rotation position. And then patients who are muscle splinting because they have, I mean, basically wear in their teeth, right? So they're posturing to avoid those interferences. Those are patients that I know that I'm not going to get an accurate initial mounting. So from there,
You're doing I'm sorry, and you're taking the bite in the dental chair or the patient
in the
sitting and you
dental
consider
chair,
leaning
and
back?
usually the patient, and the patient's usually around, it's about 45 degrees. Yep,
Okay.
exactly. And I don't do any like manipulation. You know, a lot of times people ask like, oh, do you do bimanual? I don't. I might use a little deprogrammer. So what I've done is I'll take a little piece of, especially if somebody's very difficult to manipulate, I might make a little deprogrammer, like, or put a leaf gauge in, or even put something like a tongue depressor, you know, between the teeth, just to let the patient sit for 3 to 5 minutes. And usually my assistants will recognize the need to do that, because I might be busy with the patient, so they don't want to have the patient sit with a cotton roll because they know cotton roll is going to get wet and they're going to start over closing. So they try to put something that's more rigid between the teeth.
Rigid.
And if the patient is difficult to manipulate, then or guide, I shouldn't say manipulate. If my assistant can't get the patient to relax, they come and get me and they say, Dr. Chira, the patient's difficult to, relax. What would you like to do? Do you want to make a little deprogrammer? I'll take some triad, make a flat plane, mold it over the teeth, and just have the patient rest there. And then I come back and I'll take my bite registration.
Did you notice changes in that bite registration when you put the patient sitting down, and you kind of notice any influence? Yeah, standing up or sitting normal position. Do you notice changes in that postural modification to be back and to get a standing up? Is that showing you something into that bite? You can see any retrograde path?
Yeah, so where I see changes, postural changes, are for the patients who have not been deprogrammed. Yes. So for the patients who come in for their initial bite registration, there's a measure of inaccuracy that's going to be built in. But for the patients who have been deprogrammed on an appliance, an occlusal orthotic, no, I do not see a change. Not unless they still have a behavior or pattern, right? Okay. That causes them to want to shift and move away. And those are usually the patients that I know have not been diligent about wearing their appliance. Yeah. Later on, I'm assuming when Domingo does his presentation, he shows these awesome videos where he can, and I think Salvatore Congos did the same thing. He showed that when the patient was deprogrammed and they were on their axis, it was repeatable. So yes, at the beginning, it's not going to be repeatable. But when you use an appliance to stabilize and seat the condyles properly, and you basically deprogram the neuromusculature and the pattern, then yes, it's repeatable. And it's not going to change. It's not going to change with head posture, sitting up, standing down. No. Okay. It's going to be still minor.
Tell us a little bit about the Magua plans. I just know because I see in Jeff in the mornings when we go for a run that he has his head on. And so tell us a little bit about the concept of the Magua appliance. I think it's an upper. I can see him with some canines or something that I laugh at him. But okay, so tell us a little bit what it's about.
Okay, so my experience with splint therapy has evolved since being a Roth orthodontist. So it started off as a centric relation splint, the traditional hockey puck. And then it evolved as it became more involved, becoming more of a bioaesthetic or I don't want to say biologic orthodontist, but a bioaesthetic based orthodontist. And the Mago is a maxillary anterior guided orthotic. It is a centric relation splint. However, what's carved into the appliance are the forms, the proper forms, the biologic forms that most patients present with. They don't have proper form to their teeth.
It's in the uppers and has anatomy. All over?
It's an upper, but when Jeff does his presentation, I'm sure he'll talk about the hybrid appliances where we do upper and lower appliances. And basically what you're doing is the principles of the biologic model is that you have a mutually protected occlusion. That's what a Mago is. And all you've done is you've taken a centric relation splint and you've put form on it. I describe it to my residents when I teach this. It's just a full roundhouse. That's all it is. It's a roundhouse with anatomy, all right? And you have the principles of a mutually protected occlusion built into it. As soon as they're able to visualize that, they have the light bulb goes out and their light goes on and they're like, oh yeah, that makes sense. Canine guidance, centric stops, right? Even centric stops. And then simplifying it so that all they have to visualize is just an upper appliance. I think you can do the same thing with a lower appliance. You can create a lower appliance with a mutually protected occlusion. And I think what you have to decide is, for me to start with, I like starting with an upper because the mandible is a moving target. I find it hard to stabilize a moving target and adjust it. So initially, an upper appliance is what I start with. Then what I start to see is as the patient's neuromusculature relaxes and as the condyle seats, then you start to see, okay, this patient's not tolerating an upper appliance anymore. We may have to switch to a lower appliance. And in some instances, the discrepancy is so large, you actually have to do a combo appliance, a top and a bottom appliance. But the principles of introducing a mutually protected occlusion and then establishing a proper verticalization of the chewing is what we're trying to achieve.
So,
Oh, wow.
would it be fair to say?
Go
I'm
ahead.
sorry. Would it be fair to say that in your system, when you're taking that bite, I'm assuming you're getting decompression and you're getting movement of that lower jaw forward. That's what I'm hearing with the space in the back and all that. Is that fair to say?
Am I getting movement of the mandible forward when I'm actually doing the bite registration?
Correct.
Or are you talking about the orthotic?
Well, I'm assuming the space that is created in there is because of some sort of movement and decompression in the joint.
Yes, and usually what it is you're accounting for vertical problems in that patient, right? Because the reality is if you have a patient come in, they're going to have a 3-plane problem. So what you have to do is you have to figure out for that patient, what's the amount of vertical space you need to restore function.
I think we're seeing the same things. I think we're seeing the same things. We're just maybe calling it different things.
That's right.
My question is, how about if you have a condyle, and then you see an Arnett group that we can see this amount of resorbed condyles and really weird shapes, right? So those condyles. And how you taken as a consideration this unbalanced structure of that is something. It's hard to measure boxes to make it equal if they don't have the same height. So in a condyle surface that has been reabsorbed or morphological change, that will induce the mandible to switch to create interferences or cross bites, depends on the stage that we are, create muscle balance and all that. Now you create the beauty of all this holistic approach with posture, start unrolling all the problems of the patient, and we start getting the patient, let's say, aligned, right? Let's say in all meanings, depends on the information that we have. Now we're gonna take a bite registration, and those two bone surfaces, they quite different. Now my concern is, and that's what sometimes I show a lot of that the movements that dynamically happen into the joint, is that sometimes I don't see that rotation first. And in many cases, like in the previous interview with Milio, that I use him as a patient for one of the courses, he has a huge space into the back. So I'm imagining him that I'm doing this technique, and I will say, if I up in Milio this way, it will be the gap even more discrepant for him. So how you can relate that structural changes that can happen into the condyle when you lose in substance, so you have technically one condyle shorter. How is that, how you think the system can balance? And that's why, since I'm telling you this because you have also the information of all these injection into the joints to make it grow, because you saw Alejandro Martinez and I forgot the name, but so you know that you're always trying to compensate that condyle that gets smaller. How can be taken as a consideration the different changes into the condyles when you're gonna take a bite that is still making like gliding into the rotation compartment only? I don't know if it's clear the question. Hamid, can you help to simplify it?
I understand what you're saying.
Okay.
So Javier, I think one of the things that's really important is, to me, joint stability is one of several goals that I'm trying to achieve. So I'm not just worried about like, okay, is that joint perfectly aligned, and is it and is that the only thing that matters? Is that how I measure function? That's just one aspect. So for me, what I'm looking for is, I I use imaging to make sure that the joint is recorticated. Okay, I look at the position of the joint in 3 planes of space. I'm assuming that this patient who, you know, we're talking about, let's say it's a degenerative joint patient, right? And there's asymmetries that were identified early on. What I plan on doing is, before I move forward with any form of treatment, I'm looking for the absence of symptoms and repeatability and stability throughout the whole person. Okay, so once I achieve that, then I can move forward. Keep in mind the other part that I think, because we get really caught up with just jaw mechanics, I think there's also a systemic component that you have to look at. So that integrative physician that I work with, she also, that's the supportive work that I do, determines what are other sources of inflammation that might be contributing to the breakdown of that joint. So I think we get caught up with just like mechanics, right? But don't forget the other sources of inflammation that may have resulted in that joint breaking down. You know, I think Mike Gunson has this awesome graph that he shows, and he shows that basically, you know, you can't just look at the mechanical, you've got to look at the systemic influences that causes joint instability. And I think all of that matters.
I can't wait to also bring it sometime when this is finished, but I think Mike has an awesome information, and he's fascinated about the phonetics. And honestly, we're gonna get together in some point to really blow minds ourselves.
Did I answer your question?
Yeah, you did. Thank you so much.
I think so. I think I
and I can't wait, Jeff, because now I want to see the appliances. You know, this is not a stop. I want to know more. That's great. Okay, Hamid, let's go with the questions.
Kids in a candy shop.
Yeah.
All right, questions. Last 15 minutes. We're gonna go boom, 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 boom. All right. So, Dara, today, based on your experience, what is occlusion to you?
Well, for certain, it's not just teeth; it's everything.
Okay.
And I assume, you know, just based on the interdisciplinary way I look at things, it's the teeth, it's the joints, it's the jaws, it's the lips, it's all of those influence occlusion. It's not static, that's for certain. You know, the static relationship is a way for us to see, you know, at rest, when we put our teeth together, do we have a good fit of the teeth? But what's more important is the dynamic relationships that come out of that neutral position. That's what occlusion is for me.
Beautiful.
Sounds great. Thank you. So I think you have answered this second question in parts, but you can quickly answer it. So what other factors do you consider prior to your stabilization? And you know, you've certainly talked about posture, but tell us about other things.
Before I move forward with the second phase of treatment, so when I think of stabilization, the absence of symptoms, making sure that for me, my splint therapy or my splint adjustments go from very long to very short appointments. And as I get close to that point where the length of the appointment is reduced to 10 minutes or less, then that's about when I take my check bites. So once every 3 weeks after that, I'll take a check bite to see if I have repeatability and stability. I use a technique called the shim technique to adjust my splints. And if I'm able to get all my centric stops in 10 minutes or less, then that patient's ready for new records. So then that means that the patient has reached baseline, and we take a new set of records from which I reevaluate and re-diagnose the patient from.
Awesome.
Fantastic.
What is the name of the technique? Shim technique?
Shim. Yep. Shims. It's like, it's using foil shims, Dalar foil shims, and buffalo foil shims. It's like you would, basically you're doing is like a leaf gauge if you're doing an occlusal adjustment, but you're doing it on an orthotic.
Okay, cool. Oh, nice. I didn't hear.
Perfect. All right. Let's talk about the diagnostic records that you collect. Tell us briefly what records do you collect?
It's pretty comprehensive, but CBCT, intraoral and extraoral photos, not the traditional ortho photos. We take about 30 to 36 photos of our patients. So we do also full body. Occasionally we do video. And then we always take mounted model records on our patients. And then we supplement that with the information we gathered from the new patient interview, which is usually TMJ history, sleep screening, questionnaire, medical history. And then we ask a lot of questions. I think part of my diagnostic records is the information that I gather at the new patient exam. So we ask a lot of questions about, nursing, do they know whether or not, it was a difficult birth? I mean, all of those things matter. It impacts development.
You get very deep. Yes.
I do.
And I know you, so I know how deep it's gonna be. I know you. This is gonna be. It has a lot of little letters. Believe me.
My husband says, just don't overwhelm people. But let's put it this way: it's comprehensive. It's comprehensive.
Fantastic.
That's good.
You already, this fourth question is about the instrumentation. You already talked about CBCT and the phone and videos and that. Do you use any other electronic or measuring instrument that we don't know about?
If you're asking if I use something like a TENS unit or some sort of
jaw tracking or
jaw tracker. I don't use a jaw tracker, but I use my articulator as a way for me to evaluate the chewing system.
I got you. Very well. I think the fifth question is pretty answered thoroughly already. Whether you use interdisciplinary approach or not, I think you've it's a resounding yes.
The resounding yes.
Yes. All right. So I do believe you also answered this because Javier always ends up asking too many questions. I keep telling him, don't screw up my question.
No, because I would say it's a story. Like I know what they talk about. I say I know what they lecture about. Let me get these pieces. This is the pieces that I love the most, and then
but then it becomes a repeated question. So the sequence of treatment.
We became directors and writers of a news channel in 2 weeks. What you expecting? We didn't start to do this.
Javier, can I add something to the process?
Please.
I think one of the things that's very important is we have to spend a lot of time listening and observing our patients. So the sequence of care and the way I design that is very individual based. So for some patients, they might go see the physical therapist before they come in and have records because I know that the patient needs to get some relief before I have any ability to capture any sort of right registration. Some patients need to go see a psychiatrist because I don't want to necessarily treat them because they're just not in the right frame of mind. Some patients need to go see the ear, nose, and throat person because I know that there's an airway obstruction. So it's not a cookie cutter. It's very individually based, and it depends on where they are when they come into my office. But my job is really to figure out who are the team members that I want for that patient or they would benefit from seeing and having. And then I have to be the facilitator. And I think that's the hardest thing. What Javier probably didn't share with you is Dr. McClendon is in Manhattan and Dr. Gunson is in Santa Barbara. And I'm in Barbara. Yeah. So it's collaborating and coordinating treatment. Some of my patients go to Boston for surgery. Some of them might go to Florida. So, that's why you can't have a big, busy practice. It has to be a smaller practice because it's very individually based.
That's beautiful.
So definitely, as part of that, you think taking a detailed history is probably the beginning of everything to figure out which way you're going to direct everybody, the traffic.
Yes, because if you take a detailed history, you might actually
They always say.
If you ask the right questions, you might find that there's a systemic component. There's a systemic component, and it's not just mechanical. And you don't want to miss that opportunity because it's just going to work against you.
All right.
Yeah, so, but you know what is crazy? And those 2 seconds into that one, because we believe that forms with detailed things are really important. And other people say, because I talk with people that just think cosmetic wise, and they say, why you need to overwhelm the patient with all these questions? You're gonna make every patient to feel sick. You asking me, you have this. So it's a different vision and perspective for the other side. That can be true. It can be a patient that go to you and they will say, this guy is so crazy and it's too much for me, and they feel maybe just overwhelmed by the forms itself, But the beauty is to have all this information and records. That was just the point.
Very well. All right, Dara. Do you or at which stage in your planning do you start considering facial aesthetic? By that, I could also include incisal display, gingival display, all that stuff that as an orthodontist you have to worry about.
From day one, before I start treatment, during treatment, and absolutely, it's how I finish.
So basically, that first, as soon as you have your diagnosis in mind, you're thinking, okay, this thing is going to be restorative, or this isn't going to be orthopedics. How do I make sure? How do I manage that? So
yeah, so and
fab protocol.
I'm not afraid to use fab. I'm not afraid to use composite to put form on the teeth, so I can put the teeth in the right place. When I put a bracket on, I take a step back and say, okay, what's wrong with this tooth? Is it in the right place? If it's not in the right place, then composite comes out and then the bracket goes on.
Perfect. Okay, so I think Javier mentioned this, and you guys briefly talked about it again. The PRP and PRGF and IPRF injections into the jaw joint. What do you feel about that? How do you have you incorporated in your treatments? Where do you stand with that?
I don't have any patients that have gone and had any of those treatments done. I've seen Alejandro, who's I think going to be speaking soon, and then also Bruno Ardonza.
Bruno.
Both of them are amazing, and I think that it's going to be a wonderful tool or adjunct. I think that there's a place for it. For me personally, it's just nice to know that if we need that, it's available.
Fantastic. All right, and I think we already know the answer. So, do you notice postural changes after treatment? Positive, negative, expected, unexpected? I'm assuming it is expected.
It is expected, and it's all the above. I certainly. I take final records, and I always take time to sit back and send a note to my restorative dentist. And at that point, you get to see what you really did, and it can be humbling. But the postural changes are something that we work towards moving towards neutrality. But again, sometimes the patient or the parent chooses an alternative approach that may not be optimum, and the postural changes aren't always favorable because the patient's in a rescue position at that point. You do your best.
So are you taking postural pictures all along the treatment?
I do. Beautiful. So we take initial, middle, and then always end of treatment, because that's a way for me to track their progress. And then reinforce if they need to get back to the physical therapist, or maybe they need to go see, the chiropractor, any body person that's going to help me keep the patient in the most neutral position so that they are moving.
The only take is 5 more minutes to take extra pictures, right? And then
it only takes 5 minutes. My staff might not agree. Might not agree. They roll their eyes like, "Oh no, another set of photos." I think and that's where I think video comes in. I think video is really helpful.
Now in these days that is like a virtual consultations. I think the future is gonna be to have a room full of cameras that just the patient is walking in and this is just recording everything. You know, that can be like the future, that patient get all digitalized, full body scans. This is going to be the future, not too far away, I think.
It's like Big Brother, huh, Javier?
Oh my God, honestly, technology is making amazing things these days. Everything is possible. Honestly, I was seeing some interviews about technology in face scan technique. They have a full body scan, high definition. Now they have movement into the soft tissues for face scans. Like I use static X-ray scans, but with different smiles. But here you can really see everything in motion. So I think technology is gonna give us
Technology
to
is
a
there
point that
already. The
is there. Yeah.
technology is there. It's just got to get a little bit less expensive and more available to everybody.
Yeah.
All right. Well, Dr. Chira, I think you're doing your part in this next question already, but it's sort of a philosophical that we have kind of given everybody, and it is about the field of occlusion as it is taught today in schools. And our question is that when do you think this is going to become more of a generalized approach everywhere, teaching this type of holistic view and you know, total person approach to occlusion?
Integrated unit.
That's gonna. I hope that will happen at some point in my lifetime. I think it will. It will start with the instructors. You know, it starts with the basic dental school education, the mindset there. You know, I think mindfulness and wellness is slowly creeping into the curriculum at some of the dental schools. I know they have that at Tufts. So it's just probably a matter of time, but it's not going to happen right away. It's going to take some individuals like ourselves to get the message out there. Get into the university and get into the university. You have to get into the university. And I think what they're going to argue is, where's the science? So, you know, the hard part is we spend so much time for me, I'm a clinician. But being at the university level, I'm hoping that I will have opportunities to put a research project together so that we have the science to back up the relationship between occlusion and the rest of the body.
Sounds great.
Yeah, education is going to be the only way.
We want to get optimistic.
I'm an optimist.
Very well, Doc. This is, I'm going to let Javier do the next question because I think
his question.
That's his question.
Yes.
This is going to be about, and I know you already said that you really don't think too much about the events in the.
But this is a mechanical question just because, honestly, that's why it's the last question. We didn't have it at the beginning. But I started getting questions like, so where is the condyle position? Where is the right position for the condyle? And then that's what I say, because we've seen many of the x-rays of cases, finished cases in the way that we do. And then I go and I see Domingo's x-rays, and I see too much to learn in the way that he handled the records and everything. But also at the end, I see our position is not that far away. If it's something that people compare, and it's, you know, can be just a description factor, honestly. So that's why we want to standardize, because I think when you guys gonna do lectures, if you get to show some condylar positions, we will understand, because the definition has been changing so much that sometimes I see, but an example is we're going to have the first maxillofacial case with Dr. Nelson from Venezuela, and it's a patient of mine from Colombia, and we planning the case digitally. And I make a graphic that I put in one of my lectures that I show that the condyle doesn't go all the way in a socket, that it goes like in the eminence. And he tests me and he say, that is exactly where we want the condyle. And then I say, okay, that's like a good for me, because maybe it's a misinterpretation when people talk about how they're gonna see the condyle. So can you tell us first, what do you think, which events happen in a patient when the mouth open? I'm talking without no influence. I'm talking to the patient is gonna open your mouth, or at least, let's say, freeway space, or just gonna make a full opening. What is the first event that happened into the joint? Is first a rotation, or first a translation, or is a combination? Or you're gonna talk about the internal joint or the bone by itself, like osteokinematics or arthrokinematics, because that's one of the main dogmas that or explanations for literature.
I think you said a dogma. You know, as I was listening to you, what comes to mind is you're right. There's no real consensus in the definition, but this is what I have come to believe, is that in the absence of an unhealthy situation, so in a healthy joint and the disc is in the right place, and you have, you know, anatomy that hasn't been altered in any way, to me the joint is up and forward, okay, and centered, right, coronally. Mm-hmm. And I think that initially there's a rotational component and then translation, but that's when you have a healthy joint. Now, if you have a joint that has been altered, you know, and there is also changes at the level of the meniscus and the eminence, then that's a different story. I think that I'm not as concerned about what's happening in terms of the movement at the level of the joint. I just want to make sure that what I'm doing here isn't going to compromise the ability for that joint to function in 3 dimensions, okay, mm-hmm. and that there's no pain. So I don't know if I answered your question, because I feel that there's the healthy joint and then there's the unhealthy joint. And at the end of the day, at the end of the day, what you have to do is all the other things have to support that relationship. So you want orthopedic stability and repeatability for that joint.
Yeah, no, because the only thing that we ask also this question is like for many years when we start doing neuromuscular training, we basically were more focused just in muscles, but we never even figured what was going on into the joints, mostly because the jaw trackers that we have, they were vectors, and the only point of measure was here into the middle. So we will never be able to know what happened into the condyles, but everything changed 5 years ago when we get this system that we can see the joint movements, and we stop seeing just that line that happened into the front, and now we start seeing independent joints moving. And that's when we say, okay, maybe we need to look to this level now because we have that capability. But before, we were thinking exactly the same way. As far everything is functioning here in the front, the rest is gonna be functional fine. It's just that after, just because the instrumentation we use allowed to see that. So that's what is that question. Now, when you finish your cases, so I think you answered the question. What you describe that condyle is gonna be? You just say it's superior, anterior, and medially in the axial view.
Exactly. I mean, the goal is up and forward and seated, you know, not down and forward on the eminence. I think that's the most important thing, is that you're seeking an orthopedically stable position, and the condyle's not distracted.
Yeah, the condyle.
Right. I think the verbiage is what at least, you know, when I started with Dawson, as I was telling you, the seated was, you know, all the way up and back.
Oh yeah, protruded and back. Yeah.
So every time I hear that word, you know, that comes into my mind, and I get a little bit shell shocked.
Well, that's why we don't say. That's why I try not to say centric relation. You know, seated condylar position or stable condylar position seems more appropriate. But I mean, when we were in dental school, because you graduated a year before me, the definition changed 4 times. Like, and we're trying to figure out how to take our boards. Like, which is the right answer here? And jaw tracking and
like 10 years ago or so. You know?
Yeah, exactly. So
don't give up the dates. Don't give up.
Well, I mean, it's no wonder that there's so much confusion about occlusion. I mean,
absolutely.
That last part of the question. And now, in reference now to the occlusion by itself, to the teeth relationship, what is your occlusal scheme when you finish the case? Many orthodontists, they have the tendency to want cases with more flat Wilson and speak curves, and also besides a class 1 relationship or cause-force relationship, what you're thinking into the contacts, and then you developing anterior guides on that? What is your scheme of occlusion thinking in the two relationships?
Well, you know, I think the most important thing is to have stable centric contacts, you know, a little more heavier, more defined posteriorly, light enough so that if you take some shim stock between the anterior teeth, you can actually just get some gentle resistance, okay? And then you want, you know, positive centric contacts posteriorly. And then from there, you need to make sure you have enough overbite and overjet so that you have a mutually protected occlusion. You know, I know that there were questions earlier, like, oh, do you leave a curve of Wilson? Do you leave a curve of Spee? What you have to do is you have to do what's necessary to be able to achieve a functional occlusion. But the important thing here for me is if you don't have the right forms, morphological tooth forms, then some of the concerns or the questions you ask, like, oh, what are you looking for? Well, that's dependent on the form of the teeth and the form of the joint to begin with. So if you don't have the form there, then you're not going to be able to achieve those goals. They're not going to be stable.
And that's the part that you do with,
they're not going to be long lasting, functional. So that's probably my bioaesthetic influence there, because I really believe that you have to have proper form and they have to be in the right place for them to function properly.
So that's what Jeff do for you, build up cars and make the aesthetic things to rebuild the anatomy. So that's what we will see with Jeff. Okay.
My job is to, you know, identify the positions that need to be, you know, moved, and the components are the teeth that I get to move. But I also recognize if the structures aren't in the right place, and then he and I together agree upon, okay, what forms need to be restored before, during, and after treatment, because, you know, some of this is going to require work from the very beginning before you even start to move a tooth. Those are for the more complex interdisciplinary cases. You know, for my younger patients, I identify if there's a form issue, and like I said, I'm not afraid to take composite out. That was something that probably has been the best tool for me to be a better orthodontist, because I can finish my cases better. And I'm not afraid to take a burr and do some, I hate to use the word equilibration, let's just call it additive and subtractive dentistry to get the final fit. And then also check it, you know, because you can't just have a static relationship. You have to make sure you test it. But, you know, that also, you have to get permission from parents to do that too. So not every parent, some people just don't feel comfortable with that. So that's practice management. That's a different story, you know, but that's ultimately what I like to do. Is I like to finish my cases with the end in mind. And if I have permission from the parent to do some of the dentistry myself, I'll do it. And if it's a lot of dentistry, I send it back to the restorative dentist.
So two little questions, because we finished with
questions from patients.
Yeah, we have question for here. At what time you start treating the patients, Dara? Kids, early kids? What time? What age?
What age? Oh, I've treated children as young as 5.
Okay. Now, are you using orthopedic appliances?
Earlier it'd be nicer. I make appliances. Yep, I do.
Okay, for kids. Beautiful.
Sometimes they have, most of them are palate expanders. And my own son, because he was grinding his teeth, I made him an orthotic.
You know, I enjoy too much watching your social media, because, and honestly, that was one of the that I decided to invite you, because I'm seeing the cases that you start treating the kids, and now they all grow up. Well, it's nice. Honestly, this is really emotional to see how much you follow your patient, how you're really representing the community. That's really impacting, honestly, to see how you grow. People get old, you know. Okay, we have, got older.
Question. 2 questions so far that I see.
Yeah.
Okay.
One is a quick one. Dara, can you recommend a PT in Vermont or New Hampshire, preferably practicing Rockabato techniques?
Oh, who does Rockabato technique?
But
I think there's
first,
you know,
your physician is at Rockabato, because it's many modalities.
She's not Rockabato trained. She has Rockabato she does segmental. I think I would say most physical therapists have, you know, the training in doing some segmental, and you're probably going to want to find someone who has the posture restoration and complement it with the Rockabato. I didn't answer that question. I will have to ask. I do think that there are a couple in Vermont. My bias is really more in alignment with the postural restoration approach.
Yeah, but no, he's asking preferably, but not necessarily. So if in New Hampshire or Vermont, if you have some names, if you want to tell us, or you want to post it later.
I can post it later. Let me ask.
Okay.
You know, I have enough PTs that I work with that they would be able to tell me.
Very well.
And then also we're willing in the future to get to hear one of your PTs. We're gonna, after it's over, we're planning, and then we say maybe we will do once a month of this, and maybe we have like 2 people, and so we keep some occlusion talkings, and we keep being selfish and getting more information to get more inspired and more crazy. But it can be good to see, honestly, because I saw a lecture from the PT that he works with the doctor that we interviewed yesterday, Dr. Bernaza in Argentina.
Mm-hmm.
And what I saw for what he was doing is nothing that I never seen before. It's a different approach. And I think it's good as an occlusion also to see influencers in different PT strategies, because it's a lot of people that, like Robert here in Miami, he makes a lot of breathing. Then I see another influences is people. This guy was talking a lot about the position of the legs this way, how with the occlusion, and we normally see the patients for the profile, but not much about the curves of the legs. I mean, personally, I never saw it that dramatically, and it can be part of classification. So it's a lot to learn. So eventually, we want to learn for those philosophies of the physical therapy training and alternatives, because it's really difficult sometimes to get, mostly for me that I teach courses worldwide, even that Rockabato has a huge network worldwide. Try to find some parameters in general that you can say, okay, this physical therapy, as far as controlling this, can be a good source, you know. So we need to get more informed also in that mean.
Dr. Lydia Yavic, you know her.
Yeah, from Brazil.
She has a long question. Okay, dear Dara, dear Dr. Dara, normally each one of us have a specific group of patients in our clinics, all over our practice. As Javier told that we have a lot of adult patients that has structural differences. They have traumatism in infancy and changes of growing axis, and with a lot of internal disorders. Many times, as we can recover the relation of the disc and the condyle, the phase 2 on orthodontics, that is to erupt the teeth to new position, is a challenge. Do you have a special way to deal with this?
Thank you very much.
I not being able to see these patients, I think the first thing is you have to figure out, once you've addressed the structural issues in the physical part, you have to figure out what you need to do first. You know, where's the dysfunction coming from at the level of the teeth. So to me, you know, if you have to all of a sudden erupt teeth, you have to ask yourself, okay, what happened? Why are those teeth, again, always going to asking the question, why are those teeth not in the right place? You know, what happened in not only growth and development, right, but then what happened consequentially because of trauma. And, you know, posture can be traumatic. Poor posture can be traumatic, right? So I think what you have to figure out is, once you've untwisted, so to speak, and get the patient into the most neutral position, you take a step back and you figure out, what's the first thing I want to do? And for me, you know, I always go back to looking at what is the relationship of the upper incisor within the face relative to the relaxed lip position. And then from there, I figure out what do I need to do? Because once you know where that upper incisor is, then you can kind of see what else is going on with the rest of the face. It'll become more apparent. So when we're doing any sort of diagnostics, even for my younger patients, but for any of my interdisciplinary patients, I always take some composite and I put it on the anterior teeth first, especially in the patients that have wear, because then all of a sudden I get more information and I get some biofeedback and I instantly see what's changed. So, you know, when was her name Lydia? Is that her name?
Yes.
Mm-hmm.
Yes. You know, I'd have to see the cases.
Yeah,
to
I'm
be able to
afraid this is
figure
a
out.
little
'Cause I
bit of
don't
a
think
technique question, and this is not a
Yeah.
technique course right now we're having.
Yeah.
My God, do you notice that we
goes
kind of
down.
like ortho pretty much? All the lectures that we went over is related with ortho. Like, we don't want to stop. That's
You know,
really good.
we're
You've been awesome.
Closet orthodontists.
Yeah. Oh my God, Dara, you've been amazing. We don't
Thank you
want
so
to
much.
squeeze you more.
Thank
But
you.
you see, it was fun. I tell you, this was
You're
a
right.
really good environment. It's fun. Honestly, I just know that the time passed by because my daughter is telling me, "You almost done. You almost done." But honestly, it has been a magnificent time. You're so interested. Always, I always told you that's what I like to hang close to you, where we're together. And it's so beautiful to have you here, and amazing that you guys coming in the same schools and all this beautiful connection. I think for the future we all gonna be closer and closer, and this is
Absolutely.
gonna be really nice. Thank you so much again, sweetheart, to give us a yes to
Yes,
participate.
thank you for so graciously sharing with us your experiences and your knowledge and take away time from your family to be with us today. Really
Looking forward